It is my great pleasure now to shift gears and introduce Dr. Ilan Melnick, who is on the planning committee for this meeting and is Chief Medical Officer for Passageway Residences of Dade County, Miami, Florida. I've heard this talk several times, great talk about schizophrenia, strategies to overcome the persistent challenge of medication non-adherence and its effects on patient outcomes. So Ilan, all yours, man. Good to see you. Yeah.
Hi guys, how are you today? Thank you so much for coming here today. This is really amazing. It's exciting having you all here. This Elevate to me is such an important conference as, it's one of the few in which it actually delves with one of the important pieces of training, which is what we kind of oftentimes didn't really learn in residency. And this kind of ties up a lot of it together in being able to get people early on into their training, but also people that want to move forward into their training and trying to really make it better. So I really appreciate you all being here today. My name is Ilan Melnick. I'm a psychiatrist from Miami, Florida. I do apologize in advance. I know I look like I'm 12 years old. It is a horrible existence. I know. I do blame my father. It is all his fault, as therapy has taught me. Nothing is actually my fault, so it's true too. But really what I am is a resource and hopefully give you a different perspective when dealing with long-acting injectables, as it is something that's really underutilized, and oftentimes it's really our fault, as the training component really hasn't played in, and also the areas in where and when we should actually use these medications is really not there. So hopefully by the end we'll give you a good overview of getting a better sense of where this fits in. Now, I look young and I say I'm a resource, and oftentimes people say, well, how can you be a resource when you look the way you do? Well, I'll tell you a little bit about my practices. I have 4 private offices in Miami, Florida. I have 2 high-end concierge psychiatric practices, mostly dealing with celebrities, models, athletes, CEOs from big companies. I toured with a rock band all over Europe, like relapse prevention, conflict resolution, similar to what you guys see, right? No? What are you doing? Bringing me out here? That's crazy. That's crazy. No. That's actually a very small part of my practice. One of the things that's also distinct about me is I'm not actually from the U.S. I actually grew up in Chile. Growing up in a socialistic medical environment, one of the things I learned from there is my dad always said to me, so you don't just take from your community, you always have to give back. Decided to open up a charity clinic up in the northern part of Miami in the Aventura area, right in the Dade-Broward County lines. And basically what we do there is we see what I call the in-betweeners, the ones who make too much money for government assistance, not enough money for private insurance. It's a big issue. Obamacare was supposed to fix this, and $200 a month, $7,000 deductibles. At the end of the day, they got catastrophic care, not true medical services. One of the things I learned doing this, never let money be the reason that you don't use medication that you find most appropriate for your patient, as every single pharmaceutical company has a patient assistance program, and make sure that know that people can really benefit from this with just a little bit of effort on our part. As I'll teach you by the end, we need to be advocates to our patients. And lastly, I am the Chief Medical Officer of the largest forensic community control program in the United States. We provide services for patients who have been found not guilty to reasons of insanity for first-degree felonies, so rape, arson, and murder. And we developed a paradigm in which we transition people from the forensic state hospitals into the community, and we follow them for the rest of their lives. We actually took the idea of a woman advocate from the 1800s. Today is like Women Appreciation Day, so I appreciate all women in the room. That's what I did. Women Appreciation Day. One of the things we took it from a woman advocate from the 1800s. Her name was Dorothea Dix. Do you guys know her? Really? Wow. What was she like? Because I'm a little young for that. I'm teasing. No. But Dorothea Dix believed that if you treat people with respect, you give them structure, you teach them life skills and coping skills, that's way better than just medicating them. And we've been able to take that, and one of the things that we've been able to do is we do it with no government funding. And lastly, we've had a 0 recidivism rate since we started. I took over in 2008. Right now, we've replicated in Denmark and in Finland, and we're really showing progress in those countries as well. As I'll show you, there plays a large role in cost barriers in having to manage this, and taking the government out of it plays a huge role in that as well. So, like I said, I'm a resource. I also teach psychopharmacology at the University of Miami, and I go around the world giving CME lectures in psychopharm, but also schizophrenia bipolar outcome measures. So if you guys have any questions, feel free to put them in your little paddy thingies, and at the end, hopefully we'll be able to answer. We'll also have some sessions later on. So I do need a clicker. Oh, there it is. They hid it from me, sorry. So we're going to talk a lot about long-acting injectables, and to get a better sense, these are my faculty disclosures, and we're going to do my job today, and hopefully if I do it right, we're going to describe the challenges associated with effective schizophrenia management, including medication non-adherence and consequences of its persistence. We're going to differentiate among available long-acting injectable antipsychotics in terms of tolerability, efficacy, treating a broader spectrum of symptoms, implications, and patient adherence, which plays a role too. And develop comprehensive management strategies that hopefully will support some long-term treatment of schizophrenia, mitigate medication non-adherence, and hopefully address the patient-centric barriers that we all come accustomed to. So let's talk a little bit about some persistent challenges and how we have to mitigate them. We're going to start off with understanding that experiencing first episode psychosis is a difficult challenge. So there have been a lot of different consensus and a lot of different studies that have been done to kind of explain where we need to kind of focus our treatment. One of the things that we've learned is that the earlier on into the disease state you treat it, the better the long-term effectiveness is. And one of the things that we found in dealing with this study in particular, that they interviewed patients about their awareness about mental disorders at first occurrence of psychotic symptoms. They viewed about necessity of psychiatric treatment, their perception of the role of others in initiating that psychiatric treatment, and suggestions that they may have against getting some treatment started as an earlier time in their treatment. What they found was that about 57% of the patients had at least some awareness of having a mental disorder at the onset. But 61% of the samples believed that psychiatric help was completely unnecessary in managing their treatment. A majority of patients, about 91%, perceived that others were essential in initiating treatment, but most patients thought that no change was needed in the part of the professional caregiver in order to facilitate that. Some awareness into the mental disorder on onset was related to a shorter amount of time in terms of their duration of untreated psychosis. And delaying treatment until patients themselves became aware also was a huge gap, increased the gap in being able to get those patients better. One of the challenges that we run into is this idea of anosognosia, which basically is a neurological term. It comes from what happens when people have strokes. And the neurological component of bella difference, right? Not knowing that they even have some of these deficiencies. We've learned that some of the newer data has shown that schizophrenia, this is not just a coping skill, but actually something that is neurological. And what we've been able to see that this is one of the main reasons why our patients go into the world of non-adherence, is that they don't even know that they have an illness to begin with. And we have a challenge. We have a very small window in which you can get these people better. Part of this has to do with understanding the way the brain works. We know that as early as adolescence, the brain itself starts to shrivel up. And we know this as the gray matter starts going away, but you lose the receptors onto which these medications can work on. Another challenge that we run into is the idea that with every relapse that occurs, the ventricles, the areas in the middle of the brain, start widening out. And by doing that, well, we lose a lot of the cognitive components of what we have. Henry Nasrallah did a great article explaining how this widening of the ventricles really plays a role in patients decreasing in functionality. We knew this for a while, as schizophrenia had another name. What was schizophrenia called before it was called schizophrenia? Dementia precox. It was called dementia precox because when they would do autopsies on these younger patients, their brains looked just like dementia patients, yet they were at a much younger stated age. So we've learned that the vast majority of this deterioration actually happens between the first 5 and 10 years of the disease state. And so we have this very little window, a critical years, in terms of getting these people better. So minimizing the risk of relapses and keeping their brains healthy give them the best chance of long-term functioning. We know that the patients with schizophrenia will relapse. There's been numerous studies, and this one in particular shows that about 82% have a risk of relapse over the first 5 years. And again, with every relapse, we know that there's widening of the ventricles and deterioration in functioning, We got to do what we can to keep their brains healthy. So we have risk factors in dealing with relapses. Risk factors associated with a failure to achieve and sustain remission, especially with these first episode psychosis patients, include things like insight deficits, comorbid substance use, and absence of supportive family. Usually the very narrow window, especially early on, is when they have the best family support, but towards that end of the 5 or 10-year cycle, this family support usually goes away. And all of these factors contribute, but there is a final common pathway, and it's usually the fact that they stop their medication. The use of a long-acting injectable antipsychotic is recommended with any of these patients with risk factors, and basically that means anybody with the condition of schizophrenia. So they've done these different studies, and another one here talks about insight, because that plays a big role in this. So they did a study here about 251 patients. The idea was that over a period of 2 years, in a double-blinded manner of using either Haldol or Olanzapine, that we're going to kind of get a better sense of how insight plays a role in these patients' brains. What they found is that the older age and female gender and white ethnicity were associated with more insight. Higher total positive and negative and general psychopathology scores in the PANS were associated with less insight. So the higher their PANS scores, the sicker the patient was, the less insight into their illness they had. Higher depression scores were associated with more insight. The more they knew they were sick, the more likelihood they were going to be depressed. And better neurocognitive functioning with a larger brain volume was associated with better insight as well. We also learned that more insight throughout the study was associated with a longer time of medication adherence. And insight improved significantly over the course of the study. Conclusions, though, were that multiple factors improved. But the main one here that we had to deal with is discontinuing their medication plays a big role in managing this. Stopping medication is the most powerful predictor of a first episode relapse. Patients are 5 times higher after a first episode to stop their antipsychotic medications. The younger patients are more likely to stop than the patients that have been sick for a while. And predictors of non-adherence in the first year, especially in the early adolescence, premorbid adjustment, also worsening of premorbid cognitive functioning, Parkinsonism or Parkinsonian features, and worsening of executive functioning play a role in this as well. More than about 50% of patients who discontinue or don't take their antipsychotics will relapse within 3 to 10 months. And with drug discontinuation, there's no reliable indicator to differentiate the minority who do not relapse. So there's no way that we can tell who's going to be in that risk factor group. Within about 2 years, about 75% of relapses went off medications versus 25% went on medications. And the relapse risk is 3 times higher when not taking their medication. They did a number needed to treat of 2, which basically says that for every 2 people taking a medication versus not taking a medication, they avoid the relapse for 1 relapse over a 2-year period of time. This is huge. We need to do what we can to keep these people well, and again, non-adherence plays a big role. Studies have shown that nearly half the patients take less than 70% of their prescribed doses. I mean, I'm guilty of this as well. How many times have you had a patient, or have you taken an antibiotic that after about day 4 or 5, you feel better and you're like, I don't need to take the whole 10. We see this all the time. When non-adherence is covert, it may be incorrectly assumed that an agent is ineffective, which leads to patients being on much higher doses than they really oftentimes need to be, which means that when they actually take their medication, they have more side effects. And then we see them a couple months later and they're like sick again and we're like, oh, it's not working. Let's bump the dose up again. This is something we need to do to change. So clinicians require greater awareness and suspicion in dealing with this kind of covert non-adherence. It's been shown that it's greatly underestimated. The unidentified non-adherence may lead to things like increasing dosing, going into hospitals when maybe they don't need to, being labeled as treatment-resistant or chronic, when at the end of the day, they just may not be taking their medication the way they tell us. And identifying patient non-adherence patterns is the best option. Because one of the challenges that we have is that unfortunately people with schizophrenia, patients lie, right? They don't actually tell us this. So we have a lot of factors we have to kind of get involved. First is the illness. We know that they don't have insight. They have cognitive impairment, positive and negative symptoms. The voices tell them not to take their medication. We know that we have things like physician-stated factors. One of the things that we know is that we are probably one of the worst people in dealing with LAIs. I'll show you a study later on in which Peter Wyden discussed the fact of where we need to really manage this. And it has to start with us. We need to change our perception of long-acting injectables. Caregiver factors, a lot of patients' families say we don't want them on injectables because the stigma is already passed on to them and saying they're not sick enough to be there. And in dealing with patient factors and dealing with past history of adherence or problems like that are also a role. But the medications themselves have side effects. They have adverse events. They have formulations. Their cost is expensive. These are things that we have to deal with. So it's a complex web in which we need to manage. But as clinicians, we overestimate the non-adherence. There have been numerous studies. This is one in particular, which they basically showed that the vast majority of patients do not take their medications as prescribed, more than 50%. And if the patients do take their medications, well, they actually have a good chance of doing well on them. They did this study over 3 years where they observed about 6,500 patients, and what they found is that if the patients take their medications, well, they have a chance, or a good chance, of long-term symptomatic remission, which again goes back to our goals. We need to do what we can to get these people well. So LAIs play a huge role. But part of this is how we were trained. See, I remember as a resident, my attendings would come to me and say, you'd only use LAIs with your sick of your sick, with your most non-compliant, with the ones with the biggest train wrecks. And at the time, they were right. Because when we only had choices like Haldol and Prolixin decanoate, 87% of those patients actually went and got TD or had some type of EPS. And that's pretty much all we had. So when you made the decision of using an LAI, you had to make sure that these people really needed to be going down that path of using an LAI. With the advent of Risperdal Consta, everything changed. See, but our paradigms didn't. So I challenge you all, think about the patients in which we use this, and you'll see that they were picking the right kind of patient, but the actual wrong patient itself in making that decision. You see, who are the patients with the poorest amount of insight? Who don't know that they're sick? The patients that are early in the disease state before they figure out that God's really not talking to them? Or the people later in the disease state, that tell you that I've been schizophrenic and I've been sick for 20 years and I hear voices, who have poorer insight? People early. And if we know that's true, then who are the patients that are most likely to be non-compliant? Who are the ones that are most non-adherent? Now, don't get me wrong, they're both non-adherent. But who stop it because they're well, because they're cured? As I showed you earlier, it's early. And if we know that's true, then who are the patients that are most likely to accept injectables? It's fascinating. Pharmaceutical companies for years have come to me and they said, doctor, the reason why you don't use injectables is because you don't ask your patients. And we tell them we ask our patients, but they always say no. You've heard this story? Isn't it funny, though, the ones that always say no are the guys with like 30 tattoos, 15 piercings, and tell you they're scared of needles? It's fascinating, fascinating. The problem is we're asking two distinct populations. You see, we were trained to ask that guy later in the disease state, that guy that's been held down by 5 other people, given a 5 and 2 and a punitive measure, has been told he's a bad patient, he's been told he's non-compliant. The pharmaceutical company goes to the 20-year-old, for the past 3 months, has been hearing the voice of the devil. Finally goes into the hospital, gets proper medication, and they tell him things like, what if I gave you an option in which you only had to take once a month that gave you the best chance of long-term outcomes and minimizes the chance of you ever going back into the hospital? Who's most likely to accept that? And who are the patients who have the healthiest brains, who study after study has shown that they can take these medications with the least amount of medication and still get good outcomes? It's the early into the disease state. So we need to change that mindset. So when we're dealing with first episode schizophrenia, we really need to start thinking about using LAIs as early as possible. As LAIs has been recommended in involuntary hospital stays with the goal of increasing treatment adherence in these patients. The current guidelines regarding first episode psychosis have a very conservative approach, but the new data has all shown that these people have the best chance of long-term outcomes. And given the importance of continuous treatment, we need to do what we can to keep these people well. as they have the best chance of not only the best of outcomes, but actually going back into society and being functional members of society. Because using LAIs early in the context of a shared decision-making can reduce the negative image and the stigma that not only the patients have, but that we have as well. The proof of this is not an LAI problem, but it's our problem, is the world of Depo-Provera. How many of y'all ever heard of Depo-Provera? It's a long-acting birth control Women go to their OBGYN and ask for it by name. Not because they're bad patients, not because they're non-compliant, but because it's the most convenient and best option for them. So we need to start changing that mindset. See, treating patients in the first step is particularly important to improve those outcomes. As we're hopefully able to keep that brain healthy, as minimizing the relapses, we can keep the brain from deteriorating. And many individuals in the early stages don't accept the illness for themselves. And so we need to get a better sense for them and help with the patients and help with the family members to kind of make this goal in getting those people on an LAI. They also don't have the stigma. They haven't talked to 20 other people going, I am not sick enough to be on an LAI. As the relapse rates during the first episode psychosis during the first year were over 70% in the Theonin 2,500 patient study that they did in Finland. Fewer than 50% of patients in the Finnish healthcare system continued treatment after the first 2 months. And we see this all the time. And in study of routine administrative affected relapses, and LAIs had 64% lower relapse rates than their equivalent oral medication. So if people are on the exact same medication, 64% less chance of going into the hospital and having a relapse, which means that their brains are healthier. So the use of an LAI in first episode may be more effective than oral medication in controlling symptoms, but also in preventing those relapses. And it is generally accepted that LAIs have a more favorable side effect profile as they're able to lower the peaks and raise the valleys in keeping that patient with a more consistent and predictable blood level. Medications are only as effective as their lowest point on the trough and have as many side effects as its highest peak. With an oral medication, we on a daily basis have a higher peak and a valley. Although the average may be the same, I give the example, what's the average between 0 and 100? Anybody? Math, get the calculators out. 50, right? And what's the average between 45 and 55? 50. It's the same exact average, but where would you really want to be at in terms of peaks and valleys? Treating with an LAI as early as possible, as early as the first episode if possible, can reduce relapses, number, duration of rehospitalizations, cognitive symptoms, and what is our true goal of treatment? And improve quality of life and functionality and prognosis in our patients. We need to change the mindset. If you take anything home with you today, it's that. We need to change our way of thinking. So let me give you like an overview of understanding what's out there so we get a better sense. We kind of separate this out into what was old and what was new. The old is the first generation. We deal with Haldol decanoate and Prolixin decanoate. Both of those have one thing in common, is that they were oil-based. The oil is important to note. It's actually, I do a lot of court reviews and case reviews for different lawsuits. This was actually something that came up, is the fact that the oil they use is sesame seed oil. It's an allergen to 0.1% of the US population. That's important that you document, if you're going to use any of these medications, that you document the fact that the patient is not allergic to sesame seeds. It is important to do so. But oil plays another role. The way this medication worked is that you inject the oil into the muscle tissue. It expanded the muscle tissue. It kept this big ball of oil. And as you move around, it compressed it, esterifies it, and you get little bits of Haldol, little bits of Prolixin that kind of came out over a 2 to 4 week period of time. A couple things happen with this. One, that big ball of oil is separating the muscle fibers for quite a while and can cause quite a bit of discomfort. The other, oil is a great medium for infection. If you've given enough of these, you know you've gotten things like fistulas, you've gotten abscesses, or granulomas. Well, that's that bump that doesn't go away after the patient's had a numerous number of these injections. The world of second generation will go more into detail. The risperidone world and the aripiprazole world and the olanzapine world. Each one of them have their positives and negatives in being able to kind of go out there. Well, let's tackle the risperidone world first. Risperidone and its active metabolite paliperidone containing LAIs are shown here in this list. By the way, at the end, I made a summary slide, which is available as a PDF, which if you go into your app, you'll show it. I'll show you at the very end, so you get a good summary slide of how all of these LAIs kind of work. So the newest kid on the block is actually a subcutaneous risperidone. The way this kind of works is that it's a powder and a polymer, and what you do is you mix them together and you inject it subcutaneously, not into the muscle. It formulates almost like an implant. You get a little bit of the medication all at once, so you get pretty rapid blood levels, which means that it doesn't require any oral supplementation. But the other piece to this is over a period of about 30 days, it starts degrading, and as it does, little bits of risperidone pop out. It comes in two different doses, a 90 milligram and 120 milligram, and again, needs to be given in the abdomen in a subcutaneous way. The injection interval is 4 weeks, and it's approved for schizophrenia. Risperidone microspheres was actually a sphere in which inside those spheres contains risperidone. Those spheres have different thicknesses. The ones that are less thick, well, those dissolve earlier. The ones that are more thick, they dissolve a little later. It takes about 3 weeks for any of those to actually start, and because of that, requires a 3-week oral supplementation to get the patient up to level. It is approved not only for schizophrenia, but also for bipolar, but because it degrades after about 3 weeks, there's only about a 2-week overlap, which means it has to be given every 2 weeks. Both of the risperidone injectables need to be refrigerated. Paliperidone monthly actually came out. It is the active metabolite. It uses a patented nanocrystal technology. That nanocrystal technology, using a loading dose mechanism in which you get a person on a 234 and a week later you give them a 156 and you're able to get that person up to blood level fairly quickly. It's for the treatment of schizophrenia, but also for the treatment of schizoaffective disorder in patients. Also, its injectable options are very varied, from 39 milligrams up to 234. It does not need to be refrigerated, which is actually fairly good, as we had these big refrigerators when we used the microspheres in our offices. And this one gives you a full 4 weeks in being able to give it. Then they came out with the every 3 months. So once you stabilize on that paliperidone monthly for about 4 injection cycles, well, then you can give the every 3-month injection, and now you get able to cut down the injectables from 13 once a month to now you can give it 4 times a year. Some of the starting doses are here, the maintenance doses, the half-lives are varied. Oral supplementation is only needed in the microsphere technology, as the other two do not require any. And both of the risperidones need to be refrigerated. Let's go to the world of aripiprazole. So then you have now 2 injectables that are available. You have one that is a monohydrate, another that is a Loroxal. What's the difference? Well, aripiprazole Loroxal is a prodrug. A prodrug is a drug that is completely inactive until it becomes active. Now, it uses its own body's enzymes to actually make it active, and because the rate of dissolution is actually a constant, there is a rate-limiting step. Now, for people that believe that aripiprazole and aripiprazole Loroxal are the same drug, another prodrug that we deal with in psychiatry is, how many have ever heard of Adderall? Anybody? Oh, really? Wow, amazing. How about Vyvanse? Vyvanse? So Vyvanse is the prodrug of Adderall. Okay, so if you think about Adderall only lasting 4 hours, Vyvanse between 8 and 13, the idea being that it's longer acting because of that rate-limiting step. You also get a more predictable, consistent release over that period of time as well. So why is that important in terms of the rate-limiting step? Well, the way I describe it is, imagine me having a turnstile at the end of that back door, which only allows one person to leave every minute. So if I have 10 people in this room, it takes 10 minutes for everybody to leave. If I increase the number of people here to 100 people, it'll take 100 minutes for everybody to leave, but it doesn't change the rate at which people leave the room, which means that increasing the amount of medication, increasing the milligrams, doesn't really increase dramatically the amount of medication in the bloodstream. What it does is it takes longer for it to actually be processed and get into the bloodstream, which means that if I increase the dose, I am horizontally increasing the amount of time it stays in there. Now, aripiprazole monohydrate is not a prodrug. It uses its half-life to make it a long-acting. What they found is that if you, the oral tablet had a 72-hour half-life. If you inject it into muscle tissue, well, the half-life changes to about 45 to 50 days. Why is that important? Well, now what you're doing is you're increasing the amount, and if you increase the dosing, you're going to vertically increase the amount in your bloodstream without really changing the half-life of how long it stays in your system. So that's where the main differences lie, where one will extend it horizontally while the other will extend it vertically. But at the end of the day, they are both aripiprazole, and that's important too. So in the aripiprazole monohydrate, it is approved for not only schizophrenia, but also for bipolar disorder. It is also allowed at all doses to be given in the deltoid and the gluteal. And because it uses its half-life, it takes about 14 days of oral supplementation to reach a blood level and allowing aripiprazole monohydrate to get to that level. It's available not only in a dual chamber syringe in which you twist, you shake, and you inject, but it's also available in a vial syringe, which allows more flexibility as it is a fixed dose concentration at 200 milligrams per ml, which means you can pretty much infinitely dose it any way you need to. So advantages on both ends. With aripiprazole Loroxil, it's the one that gives you the most consistent and predictable blood levels of these two, as you're able to get a more steady release over a period of time, narrowing the peaks and valleys in dealing with this. Because the amount of medication that is given above the 441, it should be given in the gluteal muscle, as it's over 2 mLs. The 441 can be given in the deltoid, as well as the new product Initio, which is a nanocrystal technology of the aripiprazole Loroxil, which I'll explain in a second. Now, with this one, you have different options. You have the 441, 662, 882, and now they have the 1064, which is an every 2-month injectable. So this one, although with monohydrate, you can only give it once a month, with aripiprazole Loroxil, you can actually give it every 2 months. Now, with the other, you had 14 days of oral supplementation, and that was the only option you had. With the aripiprazole Loroxil, they now came out with something called Initio. Initio is a nanocrystal technology version of the exact same medication. With 1 dose of oral supplementation, the 30 milligram oral dose, that one peaks and valleys fairly quickly in the bloodstream. See, the aripiprazole Loroxil nanocrystal, the Initio, that one starts at around day 3 all the way through day 21. And it covers all the oral supplementation from day 3 to 21. So while the other medication, while the oral supplementation comes down after day 1, Initio starts kicking in. And you're actually able to get a predictable blood level throughout that 21-day period. And then as Initio starts coming out of the system, that's when Aristada is actually coming in, when Loroxil is actually coming in, allowing you to have a consistent blood level from the first day. And because it doesn't matter what you're giving on in the tail end, whether you're giving the 441 all the way up to the 1064, you can use any of those doses with that Initio, with the first nanocrystal technology version of Loroxil. So you're able to get people into a 2-month regimen within 1 day. Neither of them require all supplementation. What about olanzapine? Olanzapine pamoate is a water-based olanzapine mixed with a pamoate salt. When injected into muscle tissue, you get a very consistent release of olanzapine over about 28 days. That bond to the pamoate salt is very dependent on the amount of blood that's actually touching it, the catalase, as it binds off very quickly. So if you nip a vessel, you go through a vessel, or you're in a vessel, well, you get basically an instant disassociation of the pamoate salt, increasing blood levels of olanzapine to the point where you go into a cholinergic crisis. Because of that, well, we have something called a REMS, which is the FDA requires us as clinicians, the pharmacist, and the patient, and the clinic, all of us to register, sort of like clozapine. And we have to monitor the patient for up to 3 hours, as that increased amount of olanzapine can cause something called post-injection delirium sedation syndrome, in which that can actually cause some confusion and delirium during that period of time. It's very rare, about 0.07% of injections, but it does happen. And when it does, just be aware that this is something we need to manage. These are the most common adverse reactions for all of the ones I just discussed, at greater than 5% and at least twice that of placebo. And in the late stages of clinical development, what's coming out? Well, we have the BB8017 in phase 3. That one's a 6-month implant, similar to what you're going to find in some of the birth controls. I don't know if you've seen the birth control rods. It's going to be very similar in dealing, as it is a plastic polyurethane implant. It will need to be removed after when you go put the new one in, you have to remove the old one. Paliperidone palmitate is now coming into an every 6-month injectable. That's in phase 3. So hopefully, instead of giving it every 4 times a year, we'll be able to do it twice a year. Risperidone in situ microparticles, that one is in phase 3 as well. Once monthly intramuscular formulation that doesn't require any oral supplementation. The biodegradation of this risperidone formulation occurs slowly, providing sustained and controlled release of risperidone for up to 1 month. And TV46000 is in phase 3 as well, and this is another subcutaneous injectable in which you're going to be able to use for the maintenance in adult patients with schizophrenia. So the horizon for LAIs are still there. And understanding that these new subcutaneous are technically not injectable medications into the muscle, but subcutaneous, it's a different formulation, different way of actually going, a different technology and being able to get it out there. So how do we translate this evidence into practice? How do we actually do this in getting those people better? First is understanding the advantages. First is knowing that there is no need for daily administration. I can tell you that the first person I put on one of these long-acting injectables was actually from my high-end population, in which the patient had a difficult time knowing when to take his medication. You see, he started off, he was diagnosed with schizophrenia and was hearing voices while he was in school. Came into the emergency room when I was a resident, and I remember coming in with like tinfoil on his head, cotton balls in his ears. Oh, you've seen him, right? Yeah, so you know, yeah, of course, yeah. So what I'm getting at is that these things happen regularly. He thought the FBI was trying to track his brain by using satellites, and there was this motorcycle that would constantly be going around the block, so he pretty much barricaded himself in his house. Mother brought him to the emergency room, put him on medication, and he did really well. He went out and started functioning. He told me, "I will never stop my medication." It's a great story. Was on medication, oral medication, for quite a while. One day I get a phone call. He tells me, "Doc," I'm like, "Hey, what's up?" He's like, "Listen, I have a question." I'm like, "What's up?" He's like, "Well, when do I take my medication?" I'm like, "Why?" He's like, "Well, I'm working for this company, and I just got promoted to the national sales director for this Fortune 500 company." And I'm like, "Well, that's amazing. Congratulations." He's like, "Well, when do I take my medication?" I'm like, "What do you mean?" He's like, "Well, I'm constantly traveling between the West Coast and the East Coast. In that 3-hour period, I said I will never miss it. I take it at 8 p.m. every night. When do I take it? East Coast time, West Coast time?" I'm thinking to myself, I'm like, I don't know. It doesn't really matter maybe. All right, take it at 8 p.m. no matter what time zone you're in. And he did great. Continued to take oral medication every day, never missed a dose, continued to move up the ranks in his company. One day I get a call, he tells me, "Doc," I'm like, "Hey, what's up?" It's like, "I got a question for him." I'm like, "What's up?" He's like, "When do I take my medication?" I'm like, "What do you mean?" He's like, "Well, I'm the global sales director for this company." And I'm like, "Okay." And he's like, "Well, now I'm traveling to India, over to Pakistan, up to London, back over to the US, over to Italy, constantly on a plane, constantly changing time zones." And he asked me, he's like, "When do I take my medication?" And I'm thinking to myself, I'm like, well, most of these medications have a fairly long half-life. Let's just take it at 8 p.m. no matter what time zone you're in. So here's the problem. With the stress of traveling, and we know that stress precipitates the crazy, right? And also the fact that we're having more peaks and valleys, The patient decompensated. I get an email from him saying, I think they're going to fire me. I'm like, what happened? He's like, well, you know, I sent my mom an I love you card for her birthday on email, and I think they're monitoring my email, and I think they're going to fire me because they think I have an incestuous relationship with my mom. And I'm listening to this going, are you paranoid? And he looked at me and he said, no, I'm a lot paranoid. And I told him, I said, well, the good news is, we can maybe use a long-acting injectable version of this medication that you're taking. And so we decided to switch him over. We took 2 weeks off, gave him some oral supplementation, gave him the medication, and he did great. He did great because of a couple reasons. All the paranoia went away. His thought process was more clear. But he called me up about 6 months later, and he said to me, he's like, hey, doc. I'm like, hey, what's up? He's like, you changed my life. And I said to him, well, of course I did. It's me. No. I said, well, what did I do? What happened? He looked at me and he said, you changed my life. Every day I took a pill, it reminded me of being sick. Every day I had friends that came over to the house, I was always worried that someone would find my medication and know about my diagnosis. Taking an LAI gave me freedom. We chose this not because he was a bad patient, not because he was non-compliant, but because it was the best option for him. That no need for daily administration changed his life. We know also that long-acting injectables do not improve compliance. I guess let me ask, how many of y'all believe long-acting injectables improve compliance? Yay, good. Oh, God, leading question. Come on, I just said they don't. Listen. No. This is why we had 4% on the previous lecture, that people after he gave the answer. No. The idea being here is that long-acting injectables do not improve compliance. Here's a definition of compliance. If I give you a pill today, what are the chances you're going to take a pill tomorrow? If I give you a shot today, what are the chances a month from now you're going to take a shot? That doesn't get any better. It's about the same. But what it does do is it gives you an assurance of compliance. If I give you a shot today, then I know you're being compliant. If you miss your shot today, well, then I know you're being non-compliant. The assurance of compliance plays a role. And we deal with this with patients with primary thought disorders. I mean, these people have a hard time making decisions on a daily basis, like taking a shower every day, right? I think it's a schizophrenic law. They're not allowed to shower more than 5 days in a row. I think they lose like their membership card or something. I'm not sure. But the idea being that if we know that these people have a hard time making decisions on a daily basis, how do we expect them to take a pill 365 times a year? Taking a shot once a month, that number gets cut down to 13. Going every 2 months gets cut down to 6. Going to every 3 months gets cut down to 4. And hopefully soon, every 6 months gets cut down to 2. Way more manageable with a person with a primary thought disorder. As we're hopefully able to lower relapse, we're minimizing gastrointestinal absorptional problems. We know first pass metabolism gets changed. Reduce peaks and valleys, right? And improve patient-physician satisfaction. There's been numerous studies that have shown that if a patient's on an LAI, we do one thing. So we trust the patient. We trust them. Here's an example. Patient's doing great on aripiprazole, shows up for 5 years, doing great, shows up one day and is floridly psychotic. What's the first thing that goes through your head? Non-compliance, right? If you know he's on an injectable, we can ensure compliance. Disadvantages are obviously dealing with things like stigma, slow titration, longer times to steady state, refrigeration for some of the LAIs, or the pain associated with some of the oil-based medications, and that stigma that we have and that the patients have. The detection of antipsychotic non-adherence is there. There was actually a study that was great. It was done by Janssen, which basically what they did is they had patients take their oral medication. They went and they asked the physician, it's like, well, how often are your patients compliant? And we said, well, 42%. We asked the patients, right? And they said, well, how many times are you non-compliant? We said 50% of the time, more or less, they're compliant. Patients said 85% of the time we're compliant. But then what they didn't know is that this little pill bottle in which they got their pills had a little counter on it. And what they found is close to 60% of patients were non-compliant when dealing with this. This is huge. So we need to learn how to communicate. Attrition rates after the initial therapy of an LAI is from about 15 to over 50% due to many different factors. Among things are things like patient characteristics, dosing, initiation strategies, organization of services, and how we're able to get this. People leave a hospital, have no follow-up, that kind of stuff. To help improve this, we need to do what we can to formulate that good relationship, not just with the patient, but with the family to improve their outcomes. We could suggest better communications. Peter Wyden did an article in which he showed that the main reason why patients don't want to take injectables wasn't because we didn't ask them, was because of our stigma. He went out and did this article in which he basically went out and videotaped and transcribed clinicians, whether it was nurse practitioners, PAs, and physicians, going out there and asking patients, how do you want to take an LAI? They'd pitch it to them. This is the kind of results that were there. You don't want a shot, do you? You're not sick enough for a shot, so we don't need to go down that path. This is the problem. We need to change that mindset, change our stigma. Our non-acceptance, our ambivalence is probably the most likely cause of our patients not taking an LAI early into their disease states. And if you deal with family support, that plays a role as well. Families are affected by this. The earlier you are into the disease state, that's when the families are the most likely to help. That's when we need to start talking to them about injectables and explain to them this is not a penalty. This is not because he's non-adherent, but it's because it gives him the best chance for Johnny to still be Johnny in 10 years. Therefore, they play a key role. There are our advocates too. They include things like, they include family discussions and talking to them about what would be good long-term treatments. And family members are often the ones that suffer the most because they see that their kid was recently diagnosed with a condition that is irreversible. And if we tell them, hey, you know, we give you the best chance of these people staying well long-term, we'll give them the best chance of success long-term. And in terms of cost, what is the most expensive piece of psychiatric care? Hospitalization. One day in the hospital is about, in a civil hospital, is about $700 to $800, up to $1,200 a day. In forensics, it's between $1,800 and $2,000 a day. One day in the hospital covers approximately 1 month worth of medication. Numerous studies in Scandinavia, we recently have one in the US, which show that the overall cost, if you put all the silos together, it is way cheaper to put a person on an LAI, especially early on in their disease state, than it is to put them on oral. So we need to deal with a good discharge planning, dealing with things like strong therapeutic alliances, improve patients' quality of life by securing adequate housing, giving financial planning, refer patients to educational and social programs, involve patients with his or her own care. The idea being is giving the patient the freedom to make that decision. Establish continuation of care, not just from the acute care hospital, but into the community as well. We're going to hopefully help them with living arrangements. Everything from food, housing, and clothing need to be taken care of. The social support, involve family, involve friends. Financial needs, give them the financial aid, give them help with the patient assistance program. Daily activities of employment, cooking, medication planning, how to get their medications, and community treatment plan. This is what we do at our forensic hospital. It's been really helpful in getting these people well. So this is a case from that forensic hospital. This is a woman who I first met at the state hospital when I was a resident. She's a 21-year-old female with no previous psychosis, but had acted strange in the past. High school graduate and was in college, no previous drug use, and rarely drank more than a few drinks a month. She was brought to the jail after she killed her boyfriend. She was previously on olanzapine to control some strange thoughts that she was having when she was 20 years old. She would feel that the TV was going to give her messages, and the olanzapine kept those under control. She was quite stable on the medication when her boyfriend told her that she was gaining too much weight on her medication and that she didn't need it anymore, as she was doing well. And without telling her doctor, again, the covert non-adherence, decided to stop all her medications. After a few weeks, she didn't recognize that she was beginning to hear the voices again. The insight was low. He was getting messages from the TV. One of those messages told her that she was going to be in charge of battling the devil when the world would come to an end, and that it was coming soon. One afternoon, she finally got the signal to do battle, and watching the local news through the little ticker at the bottom, the numbers from the lottery actually told her that that was a signal for her to do this. She went, and according to the message, she had to take, the devil took the shape of her boyfriend, and it was her job to kill the devil. So she grabbed a guitar, hit him over the head with it. She proceeded to call the police from the gas station across the street, asking to speak to the mayor because she wanted a parade because she had killed the devil. The police came and saw what happened, and they quickly arrested her. She spent 3 years in the Forensic State Hospital, received oral medication. When she would get transitioned to a less restrictive environment, she stopped taking her medications. When asked why, she said she was cured of her illness. She didn't need it. She finally transitioned to my forensic community control program, where she started on an LAI. We began the conversation of an LAI by asking her about her goals. She told me that when she wanted to get a job and go back to school and become a secretary. We talked about outcomes that best results from consistent and predictable blood levels. I explained to her that medications are only as powerful as the lowest trough, have as many high side effects as the highest peak, and that the LAIs help balance those peaks and valleys. And it would cut down the number of times that she needed medication from 365 times a year to 13 injections a year. She accepted, and LAIs were started. This woman's now independent, living on her own, visits her family regularly, who's been more involved with her in general. She has a better quality of life. The idea here is that we're giving patients their lives back, and an LAI is a great mechanism in which to be able to do so. She still every now and then will get some messages from things, but it's never to the point where it was before. She is doing things well for herself. Thank you guys very much for coming. I know we have some questions. This is the summary slide that we made. This is available as a PDF. You can print it out. It's going to be available as one of the links on in the app. And then you can email it to yourself. Please, by all means, get it. It's a great, great way of looking at what's available out there.
Okay, really interesting questions. We got a little bit of time, which is great. So is there any possibility for a long-acting injectable for clozapine?
Is there a possibility? Perhaps. With the REMS, I would find it very difficult for someone to invest that kind of money on something that would still create, they still have to deal with the government's need to control. So,
right, and I guess if somebody started having the neutropenic problems and it was long-term on board.
You couldn't take it away.
Yeah.
Correct.
So probably not. Sorry, guys.
Sorry. Yeah.
Please comment on the use of LAIs for adolescents younger than 18.
So a couple things. First off, just to be clear, I don't treat kids very often, mostly because it's usually the parents' fault. Yeah. Parents know, right? Yeah. But the idea is that dealing with LAIs, you've got to be very careful. First, none of them are indicated for kids. And if, God forbid, something bad happens, you're kind of on the hook for it. My advice is that there are oral medications available for this. Usually the parents are more involved in keeping and assuring compliance, so that might be helpful. There are some rapid dissolvable versions of some of these medications which help with cheeking, and I would definitely recommend an oral before going to an LAI, as none of them are indicated for it.
Right. Is risk of tardive dyskinesia higher in patients with long-acting agents?
From what I understand is that the risk of all of the side effects are equal between oral and their equivalent injectable version.
Any difference in sort of prolactin issues with long-acting risperidone, say, versus oral?
So one of the things that we know is that dopamine is also called prolactin inhibiting factor. So if you elevate dopamine, it will lower prolactin levels. If you lower dopamine or block the receptor, it will increase prolactin levels. One of the things that this does do is that it does block dopamine, but in a more consistent way. I'm not saying that it wouldn't change it, but there are medications, and especially some long-actings, that don't block dopamine. If prolactin is an issue, perhaps switching to a aripiprazole option, which doesn't increase prolactin, being a better option.
How do we transition from an oral dose to an intramuscular dose? Sort of depends, doesn't it?
Yeah, it all depends on the actual medication, the patient itself. what setting in which they're in. Again, in outpatient clinics, you can, depending on the medication, some of them require oral supplementation, some of them don't. The ones that don't, you can abruptly discontinue, and this will just kind of carry on. Some of them require an overlap of oral supplementations. Some of them, it doesn't matter what the oral supplementation is. Some of them do. That's all explained in that table that we did.
Right, so it's variable. It depends on which agent you choose, and I think that's a really important point. Here's an interesting one. How do you partner with rural PCPS? What's PCPS, I guess?
Yeah, primary care, right?
All right. How do you, with rural PCPS and/or county health departments, to administer LAIs? So if you're out in the boonies a little bit.
So we do this, actually. So one of the things that we've learned is our forensic program in our second phase, they actually live in the outpatient. Some of our patients, we've actually been able to transition close to about 40 miles away from where we're at, which makes it very impractical for them to come in on a regular basis. One of the things that we've been able to do is one of two things. One, we've been able to talk to the primary care that manages their health in that area. Injectable medications are actually billable services, and so the primary care guy is more willing to understand that if you can bill a J code for the injectable, they're more willing to give it. And so I tell them, I'm like, this is very easy. It's an easy injectable to give. You give it once a month. The patient goes in and gets it. They're usually pretty good about managing that. Other things you can do is like some home health agencies are able to go in and give their injectable as well, especially for the first couple of months after they've left a facility or left a hospital setting. And also in some states, pharmacists can actually give it as well. So I know in North Carolina and even in some states, Florida doesn't yet, but is in the process of, they can go to their pharmacy and actually have their pharmacy.
So that's another question, actually. Do you have any suggestions on how to build relationships with pharmacies to make it easier for patients to get injections without requiring the doc appointment?
Yeah, I mean, this is one of those challenges. It depends state to state. I can tell you that some of the pharmaceutical companies have actually gone out and done resources and telling you which are the pharmacies that actually will give these injectables. And so talking to your representative might be helpful in being able to manage that.
Would you still aggressively push long-acting injectable when a patient takes multiple other oral psychotropic medicines?
So one of the things that we know is that a lot of times when polypharmacy is in the mix, it's because of covert non-adherence. A lot of times they're taking half of the medications. You don't even know which half they're taking. With an LAI, at least you can guarantee that they have this medication on board, and at least that will start. Adding things on, you don't know if they're going to end up taking it or not. So I always recommend, I don't recommend polypharmacy, but if you're going to do at least one of them as an option is to be in an LAI, start that, and then possibly wean them off the other antipsychotic as you're getting more predictable, consistent blood levels and getting them better.
That's a huge point. The degree to which people don't take medicine, I just saw another study on this. It's just mind-bending. I mean, not just people with real psychotic disorders, but even people with just depression and things where there's not the same insight problems. Okay, thanks, sir.
Thanks, Chuck.
Good lunch,
Appreciate it.
always
Thank
great.
you.
Yes, great.